Good evening, all. Today we'll discuss about how we have to assess any child with gait issues. So, definition of the gait: it's a highly controlled and coordinated, repetitive series of limb movements, and its function being to advance the body safely from one place to another with the minimum energy expenditure. So gait will have different phases. Previously, they're labeled as heel strike, foot flat, mid stance, heel off, toe off, mid swing, heel strike. But now the new terms were initial contact, loading response, terminal stance, mid stance, terminal stance, and then pre-swing, initial swing, mid swing, and terminal swing. So more or less, there are two main phases. That is stance phase, where your limb is in contact with the ground, and second phase is the swing phase, where your limb is off the ground. So more or less, stance phase accounts for 60% of your gait cycle. Swing phase accounts for 40%. So this is relating to the only one leg. So from initial heel contact, that is initial contact of one leg, until it is in contact with the ground, it is a stance phase only. Okay, if you follow this shaded region, so from the start of this heel strike of this shaded leg until it is coming off the ground in the pre-swing phase, that is the stance phase only. Once it gets off the ground, it is called a swing phase until the next heel strike. So more or less, the stance phase 60%, swing phase 40%, and where your only single foot is supporting the whole weight of the body is occupying 80% of the time, and double foot support is only 11% of the gait cycle. As we have seen, there are two main phases in the gait. That is stance and swing. The stance, more or less, it is giving the stability for the whole body, and there are what problems we'll see in stance, or whether it is having any problem in the initial contact. There is normally one should have any heel striker, but instead of heel striker, if it is happening like as in toe walking, if toe is getting strike first, then there is an issue with the stance, so stability will be absent. So obviously, if there is any excessive flexion at hip, knee, or ankle during the stance phase, then it's an issue. In stance phase, in mid stance or terminal stance, their knee and hip will be in extension phase, and ankle will be flat or mild dorsiflexed. If instead of that, if there is increased flexion of the hip joint or knee joint, or there is increased dorsiflexion, increased plantar flexion at the ankle, then it's an issue with the gait. In the same way, instead of a normal extension, even if there is an hyperextension at knee, then it is called genu recurvatum. So that we should be observing in the mid stance or the terminal stance phase. In the similar manner, in the swing phase, if there is an insufficient foot clearance, then it creates an issue for the normal gait. At the same time, if there is weak muscles, it doesn't help in adequate progression of the gait. Let us know few terminologies in the gait analysis. There is step width and step length and stride length. So step width is, it is a distance between the 2 feet. So this is the step width. So whenever we see this step width is narrowing, mostly it is there in the scissoring gait. And whenever we see this step width being increased, that is wide based gait, normally we see in the cerebellar ataxia or sensory ataxia. So at the same time, step length means the distance between each feet. So between the left and right feet, the distance is called the step length. Whereas stride length is from initial heel contact to terminal heel contact. At the end of one gait cycle, it is of 1 foot. So from initial heel contact, it goes to stance phase. Then the same feet goes into swing phase and ends with the next gait cycle heel contact. So the whole cycle length is called as stride length. I think I'm clear. Is it clear?
Yeah. Yes, sir.
So we'll see common gait abnormalities. So commonly we'll see spastic hemiplegia. So again, in spastic hemiplegia, there are 4 types of spastic hemiplegia. Type 1 is very least common. Here there will be impaired dorsiflexion, and there will be passively the foot can be dorsiflexed normally. So this is the weakness of the dorsiflexors of the ankle, that is seen in the drop foot, like in any peripheral neuropathy. In type 2A and type 2B, it is called a true equinus. Why it is called true equinus means the foot is in the plantar flexion throughout the swing phase, and there won't be passive dorsiflexion. It is not possible to have a passive dorsiflexion of the ankle. So it is not due to the weakness of the dorsiflexors, but due to spasticity of the plantar flexors. So it is called as a true equinus. So again, in true equinus, there are 2 types, depending on whether it is associated with the genu recurvatum or not. If there is no genu recurvatum, it is type 2A. If there is genu recurvatum, then it is called type 2B. So you can see the angle between the lower leg and dorsum of the foot is always greater than 90 degrees in spastic hemiplegia. In type 3, along with the spasticity in the gastrosoleus, so gastrosoleus are the muscles which are helping in the plantar flexion of the foot. So if they are spastic, it results in the true equinus. Along with the spasticity of the gastrosoleus, if there is a spasticity of the hamstring muscles, it results in the jump knee gait. So jump knee, along with the true equinus, there is a jump knee also. So this is type 3 spastic hemiplegia. So here, along with the gastrosoleus, you will have a spasticity of the hamstring also. In type 4, apart from hamstring and gastrosoleus spasticity, you will have adductor spasticity. So you can see the adduction at the hip joint and some internal rotation. So if we see adduction along with the hamstring contraction and gastrosoleus contraction, it is a type 4 hemiplegia. If we see only hamstrings and gastrosoleus, it is type 3. If we see only gastrosoleus contraction, there is spasticity. Without a hamstring spasticity, it is a type 2. And in that, if we see genu recurvatum also, it is type 2B. So depending on what type of spastic hemiplegia, the treatment slightly changes. So until if it is only gastrosoleus spasticity, it is advisable to go for Achilles tendon lengthening procedures. If we see a child in this state, like having a hamstring spasticity and gastrosoleus spasticity, if we go for lengthening of Achilles tendon, Achilles tendon, without answering this hamstring spasticity, it will even hamper the gait as a child goes into even more hamstring contraction and into knee flexion. So it is an energy consuming gait. So always when we see hamstrings and gastrosoleus contraction, first we should correct this hamstring contraction. So we have already discussed. So this type 2 is the most common type of spastic hemiplegia. So what you are all observing? Anyone can answer? Anyone can describe? Usha? Sriram? Hello, no one is there.
Hello, sir.
Hello.
Hello, sir.
Usha. Can you describe the gait?
I mean, it's a mangrove walking. The pattern they walk. Hello.
Yeah. So on the right side, what's happening? What are the prominent features one can observe?
It's a circumduction gait, sir. The
Yeah,
right
before naming it,
dragging the foot. Dragging the foot
okay.
in a semicircular manner.
Yeah, dragging the foot, and there is obviously there is an impaired dorsiflexion of the
Yes.
right foot, and obviously we can't able to see knee joint.
Yes.
What is happening at the hip joint? Hip is hiking up. No,
Yes.
it is due to compensate the impaired dorsiflexion and to help in the ground clearance.
Yes.
The same side hip is hiking up. And what's happening in the right upper limb?
There is a flexion at wrist and knee joint, wrist and elbow joint.
Okay. So there is a loss of associated movements in the right upper limb. No? So left upper limb associated limb movements were there, but in the right upper limb it is absent. And slight flexion at the elbow. And fingers flexion you can appreciate, but wrist flexion is not clear. So here we are not able to see but knee joint, but here in the mid stance phase, knee, this is terminal stance, almost pre-swing phase. Before that, the knee was in extension phase only. So in the mid stance and terminal stance, knee was in extension, means it doesn't have any hamstring contraction. If it is having hamstring contraction, the gait will become type 3 gait. Okay. So here child is having only gastrosoleus contraction. So there is impaired dorsiflexion due to that. So to clear the foot from the ground during the swing phase, not to have any tripping, the child compensates with the hip hiking and circumducting the gait. In type 3, so we have already discussed, there will be associated hamstring contraction, resulting in the knee flexion. And similarly, in type 4, there will be associated adductor spasticity also. In spastic diplegia, this is other common gait what we see in our OPD. The most common cause of spastic diplegia is periventricular leukomalacia, so which is more common in the preterm deliveries. So it also has 4 types. That is true equinus, jump knee, apparent equinus, couch gait. So true equinus means, as we have discussed in the hemiplegia true equinus, there will be spasticity in the gastrocnemius, and the angle between the lower leg and the dorsum of the foot will be greater than 90 degrees, and there won't be associated hamstring contraction. That is true equinus, and it will be there in both legs. Similarly, in jump knee, there will be associated hamstring contraction. So along with that, there is a severe gastrosoleus contraction also. This angle between the dorsum of the foot and the lower leg will be more than 90 degrees. Apart from that, there will be flexion at the knee joint. So this gait is known as jump knee gait. So obviously, as we discussed in the spastic hemiplegia, whenever we see this type of gait, our concentration should be on the hamstring release rather than going for the just gastrosoleus this Achilles tendon release. In apparent equinus, as any child with spastic diplegia, as age is growing, the weight of the child will be increasing. So the result, it results in slightly reducing the angle between the lower leg and the dorsum of the foot. So with this, it will result in the apparent equinus gait. So once it progresses to crouch gait, in crouch gait, this angle completely reduces and becomes less than 90 degrees. So these two gaits were very energy consuming gaits. So before they reach these gaits, always we should help the child either with physiotherapy and good orthotics before 5 years, and at around 5 to 7 years of age, we should offer a surgical intervention. So in spastic diplegia, in true equinus and jump knee, the angle between the lower leg and dorsum of the foot will be greater than 90 degrees. In apparent equinus, due to growing age and increasing weight of the child, the angle between the lower leg and this dorsum of the foot will become 90 degrees. And in crouch gait, this will be less than 90 degrees. So almost the feet appears flat in the crouch gait. Even though there is a spasticity in the gastrocnemius, it will appear flat. So let us see this child's gait. So what's happening? So initial contact is toe, and obviously it is not able to clear the ground, and there is a toe scraping throughout the gait.
Okay. So in
And what's happening to the knee joints? So from back, it is very clear what's happening to the knee joint. In the mid stance and terminal stance also, there is still flexion of the knee joint.
Flexion of the knee.
Yeah. So what type of gait it is? So it is a type 2. Hamstrings and gastrosoleus of both legs were involved. It is type 2 spastic diplegia. There is pre-equinus gait, no? No, sorry. This is jump knee gait. Along with the gastrosoleus, there is a bilateral hamstring contraction is there. You're getting the point, no? Hello? Is it clear?
Yes, sir.
okay. So in hands, you just make her walk. Pull her and just make her walk. That's it. Okay, very nice. Very nice. Come this side. Come this side. Yes. Come this side. Come this side. Lovely. Lovely.
What's happening in this gait? So just observe the angle between the lower foot and the foot and the lower leg. Here it is clearly more than 90 degrees. But here what's happening? The angle is reduced to almost 90 degrees.
So in hands, you just.
So it is very clear in this image. Okay. So this is apparent equinus phase. So once the age of the child grows, so the jump knee gait will turn into apparent equinus, and this gait will go into crouch gait phase. So where the complete foot will be flat. So these apparent equinus and crouch gait or energy consuming gaits, and they can't sustain gait for much time. Whether I'm clear?
Yes, sir.
So we'll see other common types of gaits. We see antalgic gait. So obviously everybody knows what antalgic gait is. So gait abnormality which is due to pain in the limb. So obviously due to pain, which phase of the gait cycle will be reduced, whether it is stance phase is reduced or swing phase is reduced. Hello? Which phase of the cycle will be reduced in antalgic?
Stance phase.
Yeah, stance phase will be reduced. So in the contralateral limb, what happens? Swing phase will be reduced. Means it
Compensation.
will be rapid swing phase to have a stance to give compensation as in this in this limb with pain there will be decreased stance phase. So to compensate that one in the contralateral leg there will be rapid swing phase. So whenever anyone walking with a stick due to pain, this walking stick should always be in the upper limb, which is contralateral to the painful lower limb. So obviously, the lower limb which is having no pain and the ipsilateral upper limb will move in unison. That's why on that side only we should they should use walking stick. Trendelenburg gait. So physiologically, what happens in stance phase? There will be some inferior pelvic tilt on the weight bearing leg and some superior pelvic tilt on non-weight bearing limb. So that is physiologically what happens. That is for the purpose of foot clearance and the non-weight bearing. The hip joint will be slightly tilting superiorly on the non-weight bearing limb. But in Trendelenburg gait, what happens? Completely opposite will happen. The non-weight bearing leg will be coming down. The pelvis will be tilting downward. So to compensate that one, the patient or child will sway to the weight bearing leg side. Are you getting the point?
Yes.
Normally, whenever we stand on one leg, what happens is the pelvic tilt will be downward on the weight bearing leg and slightly upward on the non-weight bearing leg. So that is a normal phenomenon to help the foot clearance on the non-weight bearing leg. Whereas in Trendelenburg gait, the opposite happens. So if weight bearing leg has a weak abductors, so it doesn't help in pelvic tilt as what we are expecting. So opposite side there should be some superior pelvic tilt, but instead of that, due to weak abductors on the weight bearing limb, the pelvis will be tilting downward. To compensate the downward pelvic tilt on non-weight bearing leg, patient will be swaying towards the weight bearing leg. Is it clear? We'll see one example with the video. So obviously the sound leg always sags. So these are waddling gait is due to abductor hip abductor weakness. So that is due to gluteus medius or gluteus minimus or tensor fasciolata. So what's happening? So in this picture, what you are seeing, the body is swaying to which side?
Left side.
Why?
On right side, so its weight bearing is on left.
Weight bearing is on left leg.
Left
So
leg.
normally, in normal children, what should happen?
It should be opposite, towards the right side when he is walking, but because of weakness on right side, the child is bearing weight on left side. Normal.
Yeah. So normally, whenever child is bearing weight on the left lower limb, the abductors of the left side will help to keep the pelvis straight or slightly up tilt.
Up.
But here what's happening? Those abductors were weak on the left side. You're getting my point?
Yes, sir.
So as abductors are weak, the pelvis is not able to maintain in the neutral position or slightly up tilt position. It is sagging down. That is called the sound leg sags. Here the left leg, normally it is a bilateral pathology for this child. So in this picture I am talking, if we assume that only left abductors were weak, normally this left abductors will help the pelvis to keep neutral position or slightly up tilt position. Whereas here, as abductors are weak, this pelvis tends to sag down. So to compensate that pelvic sagging down, what's the body is doing? It is swaying completely to the weight bearing leg, so that to prevent the pelvic sagging down. Okay, you understood? Huh?
Yes, sir.
So whenever we see this type of gait, so to which side baby or body is swaying, that is the side of your weakness. Okay.
Yes.
So here she is bearing on the right leg and she is swaying to the
Right.
Right side.
right side. So here which abductors are weak?
Right abductor.
Right
Right abductors are weak. So she is swaying to both sides, means both abductors are weak. So to which side she is swaying, this side will be the weaker side. So always child sways to the weaker side. Dystonic gait. So it appears very bizarre, and any activity will increase those abnormal movements and dystonic posturing. Common posturings what we see in dystonic gait were inversion or plantar flexion or a tonic extension of the big toe. So that tonic extension of big toe is commonly called as striatal toe. So whenever we say striatal toe, obviously we should suspect there is a extrapyramidal involvement, that is basal ganglia involvement. For children with basal ganglia involvement having this dystonic gait, paradoxically they can walk better in a backward direction rather than in a forward movement. And they used to have a sensory geste, means they walk better with their arms positioned in a certain way. So this is specific for extrapyramidal system. Whenever they have dystonias, with sensory stimulation, they will find a way where such dystonias will subside or at least attenuate. So those were seen in dystonias or dystonic gait. So what's happening with this child? Once child is made to walk, there are dystonias in the hip adductors and plantar flexors also. So this is a child with connectors having a bilateral GP involvement. So in foot drop gait, what happens? There is a flaccid equinus posturing, and there will be passive plantar. There will be passive plantar flexion throughout the swing phase, and dorsiflexion is possible. So obviously there is no spasticity anywhere, but rather than there is a dorsiflexor weakness. So to compensate that foot drop, what happens? Child shortens the limb by flexing the knee joint excessively. So what is the difference between that true equinus in the hemiplegic gait and foot drop? So in the true equinus gait, what's happening during the swing phase? There will be extension of the knee joint, but there will be hip joint hiking up, and there will be circumduction of the same limb. But in foot drop gait, what happens? There will be excessive flexion at the knee joint and hip joint to compensate for the foot drop, and there won't be any circumduction of the lower limb. So that's how we should differentiate between, just by observing we can know whether it is a foot drop gait or it is a true equinus of the hemiplegia. So which leg is affected in this child?
Right.
Yeah. So what's happening? What is the initial contact?
Toe, sir.
So toe is initial contact. And in the mid stance phase, what is the position of the foot? Whether it is a plantar flexion position or it's flat.
Flat.
Flat. So obviously we know there is no equinus. No?
Yes.
And what's happening to the knee joint in the swing phase?
It's in flexion.
Flexion.
Sorry?
Flexion.
Flexion. So slightly increase the flexion. And what's happening to the foot in the swing phase? In the swing phase, what's happening? In the swing phase, it continues to be in the plantar flexion position, no? In the swing phase, it is continues to be plantar flexion position, and there is a toe initial contact, and foot is completely flat in the mid stance position. What's happening to the knee joint is in the mid stance it is straight only, but in the swing phase it is excessively flexing up.
Flexion.
So this child has a thickening of the sciatic nerve, so was suspected to have a Hansen's disease. We'll see this Parkinsonian gait. So obviously it is seen in the bilateral basal ganglia lesions. The child will have a stooped posture or with a decreased step speed and step height and step length. And trunk and lower extremities are usually flexed, and the patient appears to be chasing their own center of gravity. So festinate gait, what it is commonly called as, they will have short step length but with fast steps, and other associated findings will be hypokinesia, bradykinesia, and freezing. So there will be always initiation issues while doing turns or initiation of the gait. And they can't withhold their balance whenever someone shuffles them or pushes them. And obviously, due to hypokinesia, there will be reduced arm swing. And when we ask them to turn around, obviously they turn as en bloc. So they take several small steps to accomplish one turn. So commonly it is seen in adult Parkinsonian disease, but sometimes we can see in children in acquired basal ganglia diseases like Japanese B encephalitis, or sometimes basal ganglia encephalitis, autoimmune basal ganglia encephalitis, or Wilson's disease. The child doesn't have a complete Parkinsonian gait, but you can see short steps and very fast steps, and some stooping you can see in the lower limbs or the knee joint. But this child doesn't have any spasticity of the hamstrings or gastrocnemius, but still the child has that stooping posture in the lower limbs and fast and short steps. And obviously you can also observe there is a reduced associated limb movements. So can you appreciate? So there is a bradykinesia, there is a stooped posture in the lower limbs along with short and fast steps. So the child has bilateral basal ganglia lesions along with thalamic involvement. So the child was diagnosed as Wilson's disease. Let us see some ataxic gaits. So commonly ataxia can be due to either cerebellar or vestibular or a sensory type. So in sensory ataxia, it is a wide-based unsteady gait, and obviously sensory ataxia is due to dorsal column involvement. So there will be loss of proprioception. So the joint position a child can't be knowing. That's why child will have that unsteady gait. And in darkness, as visible cues will be lost, the gait will become even more unsteady, and they will have a positive Romberg's sign. So sensory gait will have a broad-based and unsteady gait, but in the night time, so we should ask in the history whenever there is unsteady gait, whether that unsteadiness is worsening during night times. So if that history they will give, then it is more favor of sensory ataxia. And when we examine, obviously one should not forget to do Romberg's test. In cerebellar ataxia, they also will have a broad-based unsteady gait, but they will have other associated findings like intention tremors, dysmetria, dysradiokinesia, nystagmus in the eyes, and cerebellar dysarthria. So cerebellar ataxia, so normally it is described as a drunkard gait. So whenever someone has drunk and he is walking, it looks like a cerebellar ataxia. So this child has presented with the ataxic gait, and on evaluation, child has a cerebellar astrocytoma. Vestibular ataxia. In vestibular ataxia, vertigo will be a more prominent symptom apart from this ataxia, and it is those children won't have any limb ataxia. Limb ataxia means point chasing or dysradiokinesia. Those findings won't be there. the direction of the fast component, obviously vestibular ataxia will be associated with the nystagmus, and the direction of the fast component of nystagmus is opposite to the involved ear. And nystagmus is reduced on fixation. So obviously nystagmus is another topic we'll discuss later. The important is to know whether this ataxia is vestibular in origin or cerebellar in origin. In vestibular origin ataxia, fast pointing and deviation of outstretched hands falls in, whereas in Romberg's maneuver to the affected side. Romberg's maneuver is by closing eyes, child is asked to walk in a straight line. Then a child moves to the affected side in the vestibular ataxia. In cerebellar ataxia, whether a child closes eyes or not, there will be bilateral swaying, or otherwise swaying to the affected cerebellar hemisphere. So there also it will be ipsilateral side only. That swaying of gait will happen. In vestibular ataxia also, during eye closed walking maneuver, the child will be swaying to the affected side only. But how exactly we differentiate, we'll see here. This is fast pointing test. In vestibular lesion, fast pointing will always be to the same side of the lesion and will occur with either limb. So we'll ask the patient to outstretch the both upper limbs, and with eyes closed, we'll ask them to touch our 2 index finger tips. So initially with eyes open, they will make them to touch after outstretching the upper limbs. Then we'll ask them to do the same procedure after closing the eyes. In vestibular lesion, if right side is affected, what happens? The fast pointing will be to the same side of the lesion and will occur with either limb. So it happens with both limbs, not just right or left. So if there is a right vestibular lesion, this fast pointing will happen to the right side with both upper limbs. Whereas in cerebellar lesion, this fast pointing happens either to the left side or right side, but with the ipsilateral limb. Is it clear for everyone? For vestibular lesion, if it is a right vestibular lesion, both upper limbs will manifest that fast pointing to the same side. Whereas in cerebellar lesion, only ipsilateral upper limb will have that fast pointing, but fast pointing will maybe either to the left or right. Hello? Is it clear?
Yes, sir.
Okay. So these are some differences between central vestibular lesion and peripheral vestibular lesion. But obviously, one most important thing to remember is in central vestibular lesions, obviously there will be associated findings. So central vestibular lesion means it is a brainstem disease. So nearer to the vestibular nuclei, some other brainstem nuclear brainstem structures will be involved. So apart from vestibular signs, so associated findings will be there in central vestibular lesions. Only vestibular signs will be there in the peripheral vestibular lesions. So that is the most important thing while examining and interpreting the findings. So gait analysis, so visual gait analysis, 3D gait analysis, we don't go into 3D gait analysis. It is done by orthopedic surgeons who are into the surgeries offered for these children with hemiplegia or spastic diplegia. For gait videos, we should have a good front light, no backlighting, clear, non-distracting background to have a good gait analysis. So these are not important. So these are what are all the muscle activities happen in different phases of the gait, and what functions those muscles were having. So in initial contact, there will be ankle dorsiflexion. So that's why you will have heel initial contact. So for ankle dorsiflexion, tibialis anterior is the muscle which is helping in ankle dorsiflexion. Similarly, in the mid stance, there will be ankle plantar flexion, isometric. So there won't be any change in the length. In mid stance, obviously, while leg is coming to have a complete contact with the foot, there will be isometric contraction of the gastrosoleus. There won't be change in the length of the muscles. So that's why it is not having plantar flexion. It is flat only. Foot will be flat, but there will be contraction of your gastrosoleus. In the terminal stance, there will be some there will be knee extension. So obviously, whenever you see knee flexion in the terminal stance, it is going into jump gait. So there will be associated hamstring. Similarly, in the swing phase, one should not have a plantar flexion at the ankle, and there should not be excessive knee flexion also in the swing phase. So at least we should remember the initial contact, mid stance and terminal stance, and swing phase. In the swing phase, one should not have a plantar flexion. Okay. Obviously, you should observe dorsiflexion at the ankle in the swing phase. That one we should remember. In the initial contact, one should have heel contact first. Whether that is there or toe contact is there, we should observe clearly. In the mid stance and the terminal stance, we should observe how the ankle is placed, whether ankle like foot is completely flat over the ground or there is the plantar flexion. We should observe in the mid stance and the terminal stance. Plus knee joint. Knee joint, there should not be flexion in the knee joint in the terminal stance. Is it clear? So if we can observe these phases in the gait, the analysis of a gait of any child will become easier. Hello?
Yes, sir.
So whenever we try to describe gait, we should always describe GMFCS level. Anybody can tell GMFCS levels? Sri Lakshmi? What is full form of a GMFCS?
Gross motor functional classification
System, yeah, or scoring.
Oops.
So if child is walking around without any limitations, it is a stage 1. Stage 2, some limitations, but he walks around without any support. Stage 3, he needs some walking aid. Stage 4, he needs electronic vehicle to move around, or someone pushing him in a wheelchair. Stage 5, that is stage 3. Stage 4 is completely dependent. He doesn't even mobilize on himself with the help of electronic wheelchair also. That is a stage 4. So that's how this gross motor functional classification system is done, and for every child we should be classifying them, and we should be mentioning this GMFCS scale in the examination. And if he is depending on any ambulatory aid, we should describe what ambulatory aid. and we should describe the type or pattern. If it is a hemiplegia, if it is a diplasia, what is type of hemiplegia, what is type of stick diplasia, we should describe. Sometimes obviously it is not always possible to fit into the noun patterns of gait. So in those situations we should describe phases of the gait cycle, what exactly happening during different phases of the gait cycle. So as we discussed it just before, so we should describe what's happening in the initial contact, what's happening in the mid stance and the terminal stance, what's happening in the swing phase. If we can describe these things, it will be very clear which muscles are affected more. So let us analyze this gait. So what is GMFCS level? So it's already answers were there. It's a GMFCS 3 as she is requiring help.
Mother's help.
So ambulatory aid here at least is mother's hand. So description, initial contact,
Toes.
toes. So what's happening in the mid stance?
Knee flexion and foot is flat, sir.
So knee appears slightly flexed, no, in the stance phase.
And stance face, it appears flexed.
Yeah. So knee is still flexed in the stance phase. And what's happening to the foot, whether it is completely flat during the stance phase or it is still in the equinus position. So that will be very clear in the side view. So you can see scrapping of the toes during swing phase, and mid stance there is flexion of the knee, and this is not completely in the equinus phase. So there is decrease in the angle between the lower leg and the dorsum of the foot. Is it clear? But
Yes.
still it is not completely flat. So what gait it is?
Equinus.
Whether it is diplasia or hemiplegia? So in the right foot, almost it is a flat in the stance phase. Is it clear? Are you able to observe here? Whereas in the left leg, it is not flat. It's still having a plantar flexion.
Plantar flexion.
Yeah. So there is a asymmetric spastic diplasia. In the left, there is apparent equinus. In the right, there is crouch. Is it clear?
Yes.
So just by analyzing different phases, what's exactly happening? Initial contact, we should be very clear. And in the stance phase, what's happening to the ankle, what's happening to the knee joint. In the swing phase, what's happening to the foot. There is a clear-cut scraping is there. So this is one type of gait. Just see. Is there swaying of the body or not? Hello?
Swaying is there, sir.
Yeah, to the which side? Whether on the weight bearing side or opposite side?
Opposite side.
Opposite side. స్వేయింగ్ ఇక్కడ ఇక్కడ బెండ్ ఉంది, ఇక్కడ స్ట్రైట్ ఉంది. సో బెండింగ్ ఎట్ సైడ్ ఉంది?
Towards the left side, no, sir.
లెఫ్ట్ సైడ్. సో ఆపోజిట్ సైడ్ ఎట్లా అవుతుంది? వెయిట్ బేరింగ్ సైడే కదా.
Weight bearing side.
Weight bearing side, yes, sir.
సో టు ది సేమ్ సైడ్ ఆఫ్ ది వెయిట్ బేరింగ్.
Weight bearing.
So it's happening even when child is bearing on the right side also. So apart from that swaying gait, so waddling gait, there is also internally hips are adducting. So this is a sinus gait, and it is characteristic for congenital myasthenic gravis, congenital myasthenia syndromes. So some types of congenital myasthenia syndrome will have this type of sinus gait. These are whenever we see this type of gaits, we should suspect congenital proximal muscle weakness, obviously. But this type of gait is more or less characteristic for some mutations in congenital myasthenia syndromes. So what's happening with this child? You describe all phases of the gait. What is the initial contact?
Heel.
Heel. So in the mid stance, how is the foot? How is the knee joint? Whether they are normal?
Extension only, sir, in mid stance.
Yeah. So there is no issue in the phase of the gait, no? But what's happening? What's the issue with the gait? Is there swaying or not?
They are swaying.
It's swaying on both sides, no?
Both sides. Yes.
So it is a waddling gait only. There is a proximal muscle weakness. So this is this child had a severe vitamin D deficiency. Once we corrected vitamin D deficiency, this weakness disappeared and had a normal gait. So how do you prognosticate any child whether he can be able to ambulate on his own or not? So there are three main predictors: ability to sit on his own, and having good eye vision, and not having epilepsy. So if child is able to sit by 2 years of age, and he didn't have any cerebral vision impairment, and child didn't have any epilepsy, so child is more likely to have a independent ambulation. That's how we can prognosticate. But if child didn't achieve sitting on his own by 2 years, and child was having cerebral vision impairment, and child also have epilepsy, then it is a poor prognostication for any child to have an independent ambulation. So coming to quick recap, hemiplegic gait, there will be dragging. So that is scraping of the toes will be there, and associated circumduction. So obviously there will be some hiking up of the hip joint will be there, along with the scraping of the toes and the circumduction of the same limb. In spastic diplegia, it is a very difficult walking. It appears as though they are walking through water. They will have short, slow steps, and they will have adducted thighs also. In high step pace gaits, lifts leg high. So with the help of knee flexion, and they bring down the feet with a slap. So it happens mostly with the sensory ataxias due to loss of proprioception. To increase that sense of joint position, they try to slap with increased force on the ground, so that at least with the touch sensation they will get the position of the joint. So here also sensory ataxia and this foot drop. So the difference will be in the initial contact. In the sensory ataxia, it is loss of proprioception, making them to have a wide-based gait and high stepping gait. Whereas in foot drop, it is due to dorsiflexor weakness, which is making them to have a excessive knee flexion to clear the ground and having that high stepping gait. So that is the difference. Why the high stepping is happening in sensory ataxia and in foot drop gait, that is peripheral neuropathy. The mechanism, the purpose is different. So in peripheral neuropathy, obviously there is a dorsiflexor weakness is there. So the initial contact will be toes only. Whereas in sensory ataxia, there is no weakness in the dorsiflexors of the foot. Just because there is no sense of joint position, they will have high stepping. But initial contact will always be heel only. So that's how we can differentiate the high stepping gait, whether it is due to sensory ataxia or it is due to foot drop. Is it clear?
Yes.
So ataxic gait, as we have discussed, it looks like a drunkard gait, or while the gait when we see someone moving in a moving train. So it's always a wide based, and it will be associated with other cerebral signs. And in hip weakness, there will be battling gait. It looks like a duck walk. Thank you. So I hope it is clear. Any doubts? Any doubts?
No, sir.
No, sir.